I want to start with a number, not to frighten you, but because once you understand what is behind it, every conversation you have with your doctor will change. Every 33 seconds, someone in this country dies from heart disease. Not a statistic that lives in a journal. A person, someone's father, someone's grandmother, someone who, in many cases, had been to a doctor recently, someone whose warning signs were there, quiet, persistent, easy to explain away. And here is the part that has never left me after all these years of practice. Most of those warning signs are not dramatic. They do not arrive like chest pain in a movie. They arrive the way a crack forms in a foundation, slow, invisible, until the morning when something gives. We are going through 9 of them today, and I want you to stay with me until we reach number 2, because that one almost never makes it into a standard medical appointment, and in my experience, it may be the most relevant to where you are sitting right now. I have been working with adults over 60 for nearly 2 decades, not in research, in rooms, in the kind of appointments where someone sits across from me and tells me, finally, the thing they have been carrying alone for 8 months because they did not want to seem dramatic. What I am going to share with you today is what I tell those people, not the pamphlet version, the real one. Before we go further, drop your age in the comments and tell me how long you have been noticing something that did not feel quite right. I read every single comment on this channel. Your experience matters, and what you share might be exactly what the next person needs to hear. Now, let us begin at 9. Sign number 9 is ankle swelling that you have started calling normal. I want to address the dismissal first, because I have heard it hundreds of times. My ankles have always been a little puffy by evening. I was on my feet all day. It is just age. All of those things may be true, but they may also be covering something specific that deserves a closer look. When the heart begins to lose pumping efficiency, a process that can begin years before any formal diagnosis, the right side of the heart is often the first to show the strain. The right ventricle moves blood through the lungs and back into circulation. When it weakens, even slightly, blood begins to back up in the venous system. The legs are the lowest point. Gravity does the rest. What you end up with is fluid sitting in the tissue around your ankles and lower legs, a process called peripheral edema. Clinical evidence gathered over decades consistently shows that persistent ankle edema, even mild, even intermittent, in people with no prior cardiac diagnosis, carries a meaningfully elevated risk of heart failure hospitalization down the line. Not people who were already sick. People who looked, by most measures, fine. What that means in your life is this. If your socks are leaving deep imprints by afternoon, if pressing a thumb into the flesh above your ankle leaves a small dent that takes a few seconds to refill, that is not just a leg problem. That is a circulation problem. And circulation problems always have a source. Press your thumb into the soft tissue just above your inner ankle and hold for 5 seconds. If the skin holds the indentation, bring that to your doctor, not as a footnote, but as the main point of the visit. For maximum benefit, pair this observation with daily morning weight checks. Cardiologists have long recognized that gaining more than 2 pounds overnight, alongside visible ankle swelling, is one of the earliest measurable signs that the heart is no longer managing fluid efficiently. The next one is a sign that most people have been managing for over a year before anyone asks the right question. Sign number 8 is a cough you have been treating as something else. Not a cold, not allergies. A dry, persistent cough, usually worse when you lie down, sometimes producing a faint, frothy quality, that has been present for weeks and that you have attributed to post-nasal drip, dry air, or a virus that never quite resolved. Here is what is actually happening. When the left ventricle, the heart's main pumping chamber, begins to work less efficiently, blood backs up into the pulmonary veins, the vessels carrying oxygenated blood from the lungs into the heart. This raises pressure inside the lung tissue, and the lungs, in response, begin leaking small amounts of fluid into the air sacs. The body's response to fluid where it does not belong is to cough. The cough is not from your lungs. It is your heart telling your lungs that it cannot keep up. What is well established in cardiology is this: a persistent cough is one of the most commonly misattributed symptoms in early heart failure. Patients spend months, sometimes well over a year, treating a respiratory cause that was never there. By the time the cardiac connection is made, the window for early intervention has narrowed considerably. Notice the pattern, not just the presence. Does the cough worsen when you lie flat? Does it ease when you prop yourself up on 2 or 3 pillows? That positional element, a cough that improves with elevation, is a clinical signal that belongs in your doctor's hands, not beside your allergy tablets. Sign number 7 is fatigue that sleep does not fix. This one is the easiest to dismiss, and because of that, it is one of the most dangerous. There is a fatigue that comes from a difficult week. And then there is a different kind, a heaviness present in the morning even after 8 hours, that makes a flight of stairs feel like an achievement, that has quietly narrowed the shape of your days without you fully noticing. I want to be precise about that difference, because most people feel it and say nothing. They assume it is age. They keep moving. They adjust. Think of your cells the way you would think of a team that has stopped getting instructions. They are still working, but without the signal, they are working on the wrong thing. When cardiac output, the volume of blood the heart moves per minute, begins to decline, the body starts making quiet decisions about where to send the available supply. The brain, the kidneys, the lungs, the muscles become a lower priority, and the result is not weakness exactly. It is that specific bone-deep exhaustion that lands before you have done anything. I have sat with hundreds of patients in their 60s and 70s who described this. Almost none of them had been asked directly whether the fatigue felt different, in quality, not just degree, from anything they had experienced before. The question to bring to your doctor is this: is this fatigue worth investigating as a cardiac symptom? Most will default to thyroid or anemia. Push gently for a full picture. For maximum benefit, pair this with a simple grip strength check. What has emerged consistently from cardiovascular research is that physical grip strength is a surprisingly reliable window into heart health in older adults, more so than many standard risk markers. Many pharmacies carry grip dynamometers. The number matters less than the direction it is moving over time. Sign number 6 is shortness of breath that you have been calling age. I want to be direct here, because this sign is the one most often absorbed into the background noise of getting older. But breathlessness has a physiology, and age alone does not explain it the way most people assume. When the heart cannot move blood forward efficiently, pressure builds backward through the pulmonary circulation. The lungs stiffen subtly because they are working in a more pressured environment. Activities that once required no thought, walking up an incline, carrying bags from the car, speaking a full sentence while climbing stairs, begin to cost something. The sign here is not breathlessness during exercise. Exercise should cause breathlessness. The sign is breathlessness at a level of activity that did not used to cause it, or breathlessness that appears unexpectedly at rest, or breathlessness that wakes you from sleep, what clinicians call paroxysmal nocturnal dyspnea. What cardiology has documented repeatedly is that unexplained exertional breathlessness, not accounted for by lung disease or low iron, is among the most common presenting symptoms in new heart failure diagnoses. And in the majority of those cases, the person had been experiencing it for well over a year before it was formally investigated. The exact sentence to use with your doctor: I am getting short of breath at a level of activity that did not used to affect me, and I want that investigated, not attributed to fitness or age. Write it down. Say it verbatim. It will change the direction of the appointment. Sign number 5 is heart rhythm irregularities you are feeling but not mentioning. This is the point in the conversation I always slow down, because this sign sits at the intersection of embarrassment and fear, and that combination keeps people silent longer than anything else I have seen. An irregular heartbeat, a flutter, a skipped beat, a momentary sensation that the heart has stumbled. is something many adults over 60 experience and say nothing about. Not because they are careless, because it passes, because they worry about what mentioning it will set in motion, because they have mentioned it before and been told it was anxiety, or caffeine, or nothing. Here is the physiology. Atrial fibrillation, the most common significant cardiac arrhythmia, involves a disruption in the electrical signals coordinating the upper chambers of the heart. Instead of a clean, organized pulse, the atria quiver irregularly, sometimes fast, sometimes slow, in a rhythm that can feel like a skipped stone across water. The condition increases stroke risk by a factor of 5, and it is frequently intermittent, which means a standard ECG taken on a day when the rhythm happens to be normal will not catch it. One of my patients, a man in his early 60s, a long-haul truck driver, came in because his wife had finally stopped asking and started insisting. He had been feeling what he called a blip, not painful, not dramatic, for about 8 months, 3 separate appointments with 2 different providers, normal ECG each time. He told me, I started thinking maybe I was inventing it. You go enough times and they say nothing's wrong, you start to wonder if you're the problem. His wife had noticed something he had not mentioned to anyone. He had stopped taking the stairs at truck stops, not because his knees hurt, because sometimes halfway up, his heart would do something, and he would have to stop and wait for it to pass. He had never connected the 2 things. He had never said it out loud. What had not been ordered in any of his previous appointments was a prolonged ambulatory cardiac monitor, a wearable device that records rhythm continuously over 2 to 4 weeks. When we placed one on him, it captured 11 distinct episodes of atrial fibrillation over 18 days. His stroke risk score came back high. He had been driving 18-wheelers across 3 states, 6 days a week, untreated. We started anticoagulation therapy and a rate control medication the same week. At his 3-month follow-up, he had had 0 documented episodes. His resting heart rate had come down significantly. He sat across from me and said quietly, I feel like someone turned the volume down. I didn't even know how loud it had gotten. If you are experiencing intermittent palpitations, even occasional, even brief, ask your doctor specifically for a prolonged ambulatory cardiac monitor, sometimes called a Holter monitor or an event recorder. A standard ECG does not have the window to catch what is happening between appointments. Quick question before we go further. Have you ever mentioned a heart sensation to a doctor, a flutter, a skip, a pounding, and been told it was nothing? Drop your answer in the comments. I read everyone, and your experience matters to how I approach what I cover next. Sign number 4 is jaw pain, neck tightness, or left shoulder ache that arrives with exertion and leaves with rest. Most people know about chest pain. Fewer know that the heart often sends its distress signals somewhere else entirely, particularly in women and in adults over 65. This is a phenomenon called referred pain. The heart and surrounding structures share nerve pathways with other parts of the body. When the cardiac muscle is not receiving enough blood, a condition called myocardial ischemia, the distress signal travels through those shared channels and surfaces in unexpected places: the jaw, the neck, the left shoulder, the upper back, occasionally even the teeth. The key is the pattern. It arrives with physical effort and resolves within minutes of rest. A toothache that appears when you walk up a hill and disappears when you sit down is not a dental problem until the heart has been ruled out. A jaw tightness that comes with exertion is not tension until the arteries have been cleared. These are cardiac symptoms until proven otherwise. What cardiac records have shown consistently is that among older adults who experience a heart attack, a significant portion present first with jaw, neck, or shoulder discomfort as their primary complaint, with no chest pain at all. The majority had initially sought care for what they believed was musculoskeletal or dental. The heart was never on the list. If this is the kind of conversation you wish someone had started with you years ago, the subscribe button is right there. We cover this every week. No noise, just what actually matters. Sign number 3 is cold sweating that has no physical cause. cold, clammy perspiration appearing without exertion, without a warm room, without fever, a pale, damp skin response that feels different from ordinary sweat, is one of the lesser discussed but clinically significant signs of cardiac stress. When the heart muscle is under strain, either from ischemia or from the increasing workload of early heart failure, the sympathetic nervous system activates. One of its automatic outputs is sweat gland stimulation, not because you are hot, because your body is preparing for a crisis it has detected and you have not yet named. What emergency medicine has documented is this cold, diaphoretic sweating arriving alongside exertional symptoms or unexplained fatigue can precede a significant cardiac event by hours, even when standard blood markers come back normal in the initial workup. Normal blood markers in people who were hours away from a cardiac event. What that means practically, if you break into a cold sweat while doing something unremarkable, making breakfast, sitting quietly, having a conversation, and it arrives alongside any of the signs we have already discussed, this is not a moment for observation. It is a moment for action, not a call to the office in the morning, an emergency. For maximum benefit, pair awareness of this sign with a resting blood pressure check if one is available at home. Cardiologists have noted that blood pressure which drops unexpectedly during rest, in combination with cold sweating, may indicate that cardiac output is already compromised. The body is compensating. The window is narrow. What comes next is the sign almost no one expects, and it is the reason I told you at the beginning to stay. Sign number 2 is waking multiple times at night to urinate when you previously did not. I know, you were expecting something cardiac, and this is, during the day, when you are upright, gravity draws fluid down into your lower body, your legs, your feet, the tissue around your ankles. A heart that is struggling does not move this fluid efficiently. It pools. But when you lie down at night, that fluid redistributes. It returns into the central circulation. The kidneys, suddenly receiving more blood volume than they have been managing during waking hours, respond by producing more urine. This is called nocturnal diuresis, and it is one of the most overlooked early signs of reduced cardiac output in adults over 60. Not a prostate problem, not a bladder problem, often a heart problem expressing itself through the kidneys at 2 in the morning. I have sat across from patients who spent 3 or 4 years managing what they and their doctors believed was a urologic issue. Medication, procedures, specialist referrals, never once having been asked whether the nighttime waking had come on gradually alongside other changes. When that question is finally asked and they sit with it, the timeline is always illuminating. The waking at night began around the same time as the fatigue, the same time as the ankle swelling, the same time as the breathlessness on stairs. The body had been describing the same problem in 4 different languages, and every symptom had been routed to a different specialist. What cardiovascular research has established is that a notable proportion of adults over 65 with frequent nighttime urination and no prior cardiac diagnosis are found on proper evaluation to have measurable reductions in heart function. The connection is almost never made because the complaint is framed in urologic terms from the very first appointment. The action here is to stop managing symptoms in separate compartments. If you are waking at night to urinate and you have also noticed fatigue, ankle swelling, or reduced exercise tolerance, bring all of it into one conversation with your doctor. Write it down before you arrive. The pattern is what matters. And the pattern is invisible if only one symptom is presented at a time. Now, we have reached number 1, and I want you to prepare yourself, because this one will change how you think about the word healthy. Sign number 1 is the complete absence of symptoms in someone with significant risk factors. No flutter, no swelling, no breathlessness. Feeling, by most measures, fine. Advanced cardiac imaging has revealed something that should change how every person over 60 thinks about their health. A significant proportion of adults who report no cardiac symptoms and have never been diagnosed with heart disease are found to have meaningful subclinical cardiac changes when looked at carefully. Changes invisible to standard blood panels. Changes invisible to the individuals themselves, who walked in feeling well and walked out with a finding that changed their clinical picture entirely. No symptoms. No sense that anything was wrong. Here is the counterintuitive fact I want you to carry out of this conversation. Feeling well, in the presence of risk factors, is not the same as being well. In almost every other area of medicine, symptoms drive investigation. You feel something, you report it, it is evaluated. But the heart, unlike almost any other organ in the body, can sustain significant functional and structural decline before it produces reliable symptoms. By the time symptoms are consistent enough to bring someone to a clinic, the most favorable window for intervention has often already passed. The risk factors that make silence dangerous are these: high blood pressure, diabetes or prediabetes, elevated cholesterol, a BMI above 30, a history of smoking, or a first-degree relative who had a heart attack before 70. If you carry 2 or more of these, feeling fine is not reassurance. It is a reason to look more carefully. The specific tool to ask about by name is a coronary artery calcium score. It is a non-invasive CT scan that takes minutes, requires no contrast dye, and provides direct information about plaque burden in the arteries surrounding the heart. It is one of the most precise early warning tools available for this age group, and it is almost never offered unless you ask for it. The sentence to bring to your appointment: I would like to discuss whether a coronary artery calcium score is appropriate for me given my risk profile. Write that down. It opens a door that a standard checkup does not. You came into this conversation thinking about symptoms. I want you to leave thinking about signals, because those are different things. Symptoms are what the body says loudly. Signals are what it says before it raises its voice. The gap between a signal and a diagnosis is where the most meaningful choices still live. And now you know where to look. Now, if what we covered today has your attention, there is one more place the body hides its warnings that almost no one thinks to check. I covered it in a recent video, specifically, what happens inside your arteries between 3 a.m. and 6 a.m., and why that window matters more than any other part of the day. The link is right here. I will see you there.